Research from the United States is suggesting that there's a safer way for women to take hormone replacement therapy around the time of the menopause. Women have been in fear of HRT for many years, since a large randomised trial called the Women's Health Initiative found increased risks of heart disease and breast cancer. And that's left women with unacceptable symptoms like hot flashes without very many alternatives to HRT. But one of the researchers from the Women's Health Initiative thinks there are safer options.
So in 1991, WHI was launched. It was a study to evaluate the risks and benefits of hormones, estrogen alone and estrogen plus progesterone, to look at risks of and benefits, primarily actually of heart disease. We were expecting to find benefit. Dementia, again expecting to find benefit. And then other outcomes that were evaluated. Breast cancer was found to be quite important, certainly by the end of the study.
And the findings weren't what you expected?
They were not.
So it was combination therapy, progesterone and estrogen, that created the increased incidence of heart disease and breast cancer, not estrogen alone.
Yes, so that portion of the study has become very important for me as a clinician. The first and most important message as a clinician I learned from that trial is I'm no longer giving hormones for prevention. I use hormones now for treatment of symptoms. Rarely when I say don't give for prevention, I give for treatment of osteoporosis, but again, not prevention of osteoporosis. And to treat women with symptoms, we've modified the regimens that we recommend.
To understand how Dr. Reid has modified her treatment, I need to explain a little bit about HRT. You see, if a woman has not had a hysterectomy, in other words, still has her womb, she needs combined HRT. That's estrogen with a progesterone, because estrogen alone stimulates the lining of the uterus and increases the risk of uterine cancer, and progesterone counteracts that. The thing is, though, that the Women's Health Initiative found that it was the progesterone that caused the harms. So what Dr. Reid does is minimize the amount of progesterone or progestin given.
I minimize the progesterone effect by either giving what we call long cycle progesterone. Today when I treat for women that are not at high risk for problems of the uterine lining or the endometrium, I give what's called long cycle progesterone, and they get 2 weeks of progesterone quarterly or 4 times of the year to decrease the amount of time that the body is exposed to progesterone. And this seems to be an adequate dose to allow for prevention of overgrowth of the endometrium, which is why we were originally giving the progesterone.
And that's because of the risk of cancer of the uterus, the lining of the uterus, the endometrium, with estrogen alone.
So endometrial cancer or precancer can develop in unopposed estrogen. The other really important fact there is that is a dose-related event. So if you can bring your estrogen doses lower, then your risk for endometrial cancer will decrease. So I've done both of those things. I've decreased my estrogen doses and I minimize my progesterone systemic effect.
So women do get some bleeding?
They get bleeding quarterly, and predominantly women that are closer to that final menstrual period will bleed. So women with symptoms tend to be in the 1 to 2 years prior to their last period, and then in at least the couple of years following, and up to 5 years following that final period. We are treating women for symptoms.
But there isn't much evidence to support that, is there?
There is some reasonable data out of Scandinavia on long cycle progestin. There is a risk for endometrial hyperplasia. So as a gynecologist, I do this using tools like transvaginal ultrasound to make sure that women are not getting overgrowth. So what I will do is a baseline ultrasound looking at the endometrium, treat with the long cycle. If women get any spotting or bleeding between their cycles, they're instructed to come in immediately. And I get at least 3 ultrasounds, so I have at least 3 time points to show that I'm not getting an overgrowth over about 1 to 2 years period of time.
So this is not for the casual, non-specialist general practitioner?
Yes and no. I mean, I think If done appropriately with transvaginal ultrasounds and you don't see an overgrowth, it's a very safe method. With using the lower dose estrogen, so that's the other key component here. The estrogen used in the WHI was conjugated equine estrogen, or Premarin, 0.625 milligram dose. If you look at an equivalent dose for that for hot flashes, estradiol is approximately a 1 milligram dose. I'm now treating with a patch, a 25 microgram dose patch, 40 times less the dose than what was given in WHI.
Does that low dose of estrogen control the symptoms like hot flashes?
We don't see the exact same benefit from these doses, but what we're seeing is that women will tolerate some hot flashes. They'll tolerate a little bit of night sweats. But if overall their symptomatology is better, their quality of life is better, with education, I'm finding my patients are very willing to take these lower doses so that they are not having the adverse effects that we saw from the doses and the types of hormones given with WHI.
One of the controversies in Australia is the growth of compounding pharmacies. Pharmacists making money about so-called individualization of therapy for women through natural compounds, making up their own preparations. What's your view about that?
I think there is a great debate on whether natural hormones are better than, say, Premarin, for example. Premarin is a very natural compound. It's a compound that comes from nature, from horses. Estradiol, in the formulations I'm giving, is natural. So it is estradiol in a patch formula. It's FDA approved, and there's excellent quality control around those products. I think a number of the compounding pharmacies do an outstanding job. They're excellent. The problem is, in the States, we don't have any regulatory body over these pharmacies. And
nor in Australia.
Yes, so there's nothing to assure the woman or her provider that what is supposed to be in that compound truly is. In the States, we've done some studies looking. So we've taken compounds from pharmacies, compounding pharmacies, and we did this in the Northwest recently. And the findings were appalling and concerning to me as a clinician. So,
what did you find?
Well, that some compounds had nothing in them, some had things in them that they were not supposed to have in them, some had contaminants. Some of the products were outstanding. So again, that speaks to my point. I think there's some wonderful, excellent compounding pharmacies. We just don't have regulation over them.
You've also been looking at non-hormone ways of treating the symptoms of menopause.
So we know, certainly from studies over the last 10 years, SSRIs, or compounds, selective serotonin reuptake inhibitors, or compounds used for mood or depression, have been used for hot flashes, particularly in women who have had breast or ovarian cancer. We recently looked at one of these compounds, escitalopram or Lexapro, and we found benefit with escitalopram or Lexapro for hot flashes. We have not had any head-to-head trials, so I think
so you can't compare it to estrogen.
No, so the next question for women is, how does that compare to estrogen? We have an ongoing trial right now looking at that.
You've also studied black cohosh.
Yes.
And the soy diet.
This is a 5-arm trial with estrogen, and we used exactly the same compound used for Women's Health Initiative, placebo, single black cohosh, and a multi-botanical containing black cohosh, then a multi-botanical with black cohosh, and a soy diet. We saw no benefit with black cohosh, the multi-botanical, or the soy diet, and we saw tremendous benefit if you looked at the difference between placebo and the estrogen, not surprisingly so.
People have said there are serious side effects from black cohosh. Did you find that?
We did not. Now, for the doses that women take black cohosh for menopause symptoms, you really should not be concerned. It's mainly liver toxicity that's been described. Those are very high doses, or may have contaminants. Again, it gets back to this issue. Not dissimilar from the compounding pharmacies, these products or supplements are not made with the rigor or the oversight that the pharmaceutical compounds are made. So.